Okay, welcome to the Society of Critical Care Medicine's Project Dispatch webcast. Surgical fires are preventable medical errors. This session is part of the unique webcast series, Patient Safety During Bedside Procedures in the ICU. My name is Roy Constantine. I am co-chair of the Patient Safety Committee, Society Critical Care Medicine Surgery Section, and Secretary of the Council for Surgical and Perioperative Safety. I am also the Assistant Director of Mid-Level Practitioners at St. Francis Hospital, the Heart Center in Roslyn, New York. I have no financial disclosures to disclose. Today's webcast is supported by a grant from the Agency for Healthcare Research and Quality. The content is solely the responsibility of the presenters and does not necessarily represent the official views of AHRQ. This webcast will include approximately 40 minutes of content. Due to the short nature of this educational activity, there will not be a CE or CME offered. You are invited to ask questions for our presenter throughout the webcast. You may do so by typing your questions into the question box in your GoToWebinar panel. Questions will be addressed after the presentation. You will also have the opportunity to participate in several interactive polls. When you see a poll, simply click the bubble next to your choice. This webcast will be available at www.sccm.org/projectdispatch or on Society of Critical Care Medicine's YouTube channel within 3 business days. We invite you to share this and the many other Project Dispatch webcasts and patient stories with your colleagues widely. Post on Facebook if you like this webcast or continue the conversation on Twitter using hashtag Project Dispatch. It is now my pleasure to introduce our presenter today. Soham Roy, MD, FACS, FAAP, is Vice Chairman of the University of Texas at Houston Department of Otorhinolaryngology and the Chief of Pediatric Otolaryngology for UT and Children's Memorial's Herman Hospital, and serves as the Assistant Dean of the University of Texas, Houston Medical School for the Office of Student Affairs. Dr. Roy received his undergraduate degree with highest distinction from Stanford University, received a full scholarship in medical education at Washington University School of Medicine in St. Louis, then completed his residency in otolaryngology, head and neck surgery at the University of Miami. He completed the Pediatric Otolaryngology Fellowship at the Children's Hospital of Pittsburgh in 2002, prior to joining the faculty at the University of Miami, where he was named Professor of the Year in 2003 and again in 2006. He was recruited to join the University of Texas in 2009 and named Professor of the Year in 2013. Dr. Roy is board certified by the American Board of Otolaryngology and is a fellow of the American Academy of Otolaryngology, Head and Neck Surgery, the American College of Surgeons, and the American Academy of Pediatrics, and holds leadership roles in numerous specialty societies. An internationally recognized speaker and author, Dr. Roy has given hundreds of lectures and authored numerous scientific articles, book chapters, and research presentations. He has received multiple awards for teaching, clinical care, and original scientific research, and received the Honor Award from the AAO for his contributions in research and teaching. He is the international surgical expert in operating room fires and is an integral physician leader with both the FDA and Joint Commission committees on prevention of surgical fires. He is a recognized expert in operating room safety and serves as a consultant in the development of innovative and safer surgical devices. In his spare time, he is an accomplished violinist and recording artist and is an avid athlete. Dr. Roy has no financial relationships to disclose. Now I will return the program over to Dr. Roy.
All right. Well, thank you so much, Dr. Constantine. I appreciate the kind introduction. The key to writing a good bio like that is to just write one for yourself, and it always makes you sound good. So thanks very much for reading my own words to me. I sound terrific. I appreciate it. So very quickly, just by way of introduction, my name is Soham Roy. Before I moved to Texas, I was actually in practice at the University of Miami, and this is the view from my condo in Miami. For those of you who have been to Miami before, you can see South Beach on your left and Key Biscayne on your right. This is the view from my balcony, and after about 6 years, I was recruited to Houston, where they said, you know, this is a wonderful place to work. This is a wonderful place to be a single guy. And I promise if you come here, we'll even upgrade your view. And here is my view from Houston, Texas. So thank you, University of Texas, for this wonderful opportunity. And this has been a great place to work. I've had a really wonderful opportunity to improve my research and to work on my clinical skills. Just a quick word about my division. I'm the chief of pediatric ENT at UT. The UT ENT department is about 17 physicians now. There are 3 of us who do specifically pediatric ENT. My wonderful partner, Sanjak Yuxel, and our newest partner, Dr. Jiang. And then they decided they needed a division chief who would add a little bit of insanity into the mix. So they added me into the mix. And that is my new bio picture on the University of Texas website. And very quickly before we start, because I'm in academia, you know, they always insist that we brand our logo everywhere. So I have to put on the University of Texas Medical School logo before I start any slide presentation. I also have to put my sponsoring hospital organization, Children's Memorial Hermann Hospital, which is part of the Memorial Hermann Tech careers, and figuring out kind of what direction your career is to take. My advice is don't get famous for a complication, and that's exactly what I did. Because if you get into something like surgical fires, you either had a bad experience or you're a little bit of a sociopath. And I understand that there are some people on the call here from the University of Texas. I would ask you to refrain from commenting under which of those categories I might fall. I actually had a bad experience about 8 years ago. We were doing a routine endoscopic airway surgery, and somebody left a light cable sitting on top of the drape. And within about 10 seconds, you can see the picture at the bottom here, burned a hole into the drape within about 10 seconds, and the patient would have been terribly burned, except we'd already moved the patient off of the operating room table onto the stretcher. And so just by that good fortune, the patient wasn't seriously injured. And I remember just saying that day I was going to dedicate myself to making sure patients didn't get burned or lit on fire in the operating room, and started studying this from a scientific perspective, and it led to all the things that I'm going to talk to you about today. So let's talk about some basic information. First of all, how often does it happen? Well, that's the funny thing. Nobody really knows. There's been a lot of predicted information on how often fires happen in the operating room. And there's been some speculated, extrapolated data that suggests that it occurs anywhere from 200 to 650 times per year, with 3 to 4 times as many near-miss events, and possibly up to a 20% mandatory or a 20% mortality rate. But here's the interesting thing about it. Like, I was operating this morning, right? I can light somebody on fire in the operating room and not have to report it to anybody. I could walk out of the operating room and go about my day like any other day. Now, you're going to hear about it from your risk managers, from your hospital system, but there's no mandatory centralized reporting system. And that's why the data is so unclear. But the latest extrapolated data that we have suggests that there are probably closer to 250 incidents like this per year, and we'll talk about when these things occur. Now, many of you right now are thinking, well, we're critical care docs, and we don't really make it into the operating room, so why am I worried about surgical fires? Well, the thing is, it doesn't just have to be in the operating room. They can happen at the bedside all the time, and if you look at lists of cases where they've occurred, look at some of these lists. Temporal artery biopsy. Temporal artery biopsy, you think, oh, it's just a routine little minor procedure in the ICU. That's a huge setup for an operating room fire. Bedside tracheostomy. Your ENT doc comes in and says, there's a mass on the palate. We're going to biopsy it real quick, and you think, nothing really big. Guess what? You can light somebody on fire that way. Same thing doing PDAs at the bedside in pediatric ICUs, since I do a lot of pediatric stuff. Pacemaker placement, for those of you who are getting pacers placed. That's a risk for fires. So these fires don't just have to occur in the operating room. They can occur just about any place that procedures are performed, and we're going to talk about kind of what to expect and how to prevent those things from happening. So when you look at where fires occur, about 70% of them occur on the patient, so somewhere on the patient's skin. And about 30% are occurring either in the airway or someplace else on the body. And of those fires that occur on the patient, as you can see in the diagram on the right side, a little less than half are occurring in the head, neck, and upper chest. That tells you is whenever you have a procedure that's involving the upper chest, the neck, or any part of the face or head, that's where your red flag should really start to go up. And you should be concerned and have an extra sort of an extra heightened level of awareness. Similarly, there are a lot of misconceptions about operating room fires. First, people think that iodine-based skin preps are flammable. They're not. Alcohol-based skin preps are flammable, but iodine-based preps are not flammable. People think that lanugo hairs, like you find on your skin, are highly flammable in room air. They're not flammable in room air. They're flammable in oxygen. There's a misconception that drapes can be treated to be fire retardant, but there are no such thing as fire retardant drapes. We can't make fire retardant textiles in oxygen-enriched environments, so any sort of drapes have the potential to propagate fires. And there's a huge misconception that if you have a fire, you should grab a fire extinguisher first to fight it. That's not correct, in fact, and we'll talk about management strategies for when you do see the fires. And it's interesting because it wasn't until about 2008 when people started paying attention to these operating room fires. And the first real clear documentation of how to handle it came out with the ASA algorithm and their practice initiative on prevention of operating room fires. And if you get a chance, this is only about a 5-page article. It's a wonderful article to read. It's 5 pages. It only takes a few minutes to read. And at the end, they have this algorithm. This algorithm looks a little bit complex, but I'll break it down for you simply. The first part of operating room fires is to try not to start a fire, okay? Preventing the fire. The key to preventing that fire is communication, and we're going to emphasize the importance of communication this afternoon over the next half hour or so to prevent these fires. If for some reason your communication breaks down and you develop a fire, then the next step is to put it out. And that's important because you put it out before you save the patient. Your first instinct is to save the patient when it has to be to put the fire out first, then pay attention to save the patient. The problem is that these fires, boy, when they happen, the news media gets all over them. And there are all kinds of amazing and horrific stories about fires that have happened in the operating room. You can see just a couple of examples here in the newspapers. This is a terrible story. It happened in Ohio. It's a beautiful young woman, and thankfully she recovered and looks fantastic. She's a beautiful young woman who was burned during a simple mole excision. She was having a mole excised from her face, and a fire lit up and left her with these horrible burns. But thankfully, she recovered rather well. There was a routine case just not too long ago, a couple of years ago, in Florida. And, you know, everything terrible happens in Florida since I lived there for a long time. This is somebody who's having a little cyst removed, and you can see that she had a flash fire and ended up with just a terrible burn on her face. And, of course, in Denmark, this is a great story. A gentleman was having a mole removed from his bottom. They were using an electrocautery knife, and an attack of flatulence was ignited by a spark, which lit his genitals on fire. He lit his penis and a scrotum on fire. That's a terrible thing to have happen. The surgeon said it was an unfortunate accident. Well, what I want to pose to you is that this is not an unfortunate accident. This is something that was completely preventable and shouldn't happen. And I would ask all of you to pay attention to these risks during these cases. Because if you don't pay attention to it, let me tell you that the lawyers are paying attention to it. I guarantee you this. Operating room fires represent the second most common cause of injury and liability during monitored anesthesia care cases. And 95% of those fires in the original papers that were reviewed were involving the head, neck, and face region. 50% were cited for substandard care, and 90% resulted in a payment to the plaintiff. Now, I'll point out to you that this paper is from 2006, and you can tell because the range of the payouts was $8,000 to $321,000. When you look at more recent data, which is by the same author, he updated it in 2013, he looked at 103 closed claims and found some very interesting data. Again, 85% head, neck, and upper chest. So head, neck, and upper chest are where the biggest risks are. 84% involved an open oxygen source, either face mask or nasal cannula. We're going to talk about why that's so important. And, of course, the lawyers love to get a hold of this. This is the California Serious Injury and Wrongful Death blog, and I apologize that it's a little bit blurry, but you'll notice in 2009 they are trumpeting on the web that they got a $1.3 million verdict in the case of a mole removal that resulted in a spark. But here's more recent data, and I actually was involved in trying to mediate and settle this lawsuit. And as you can see, I did a really terrible job. I'm not a good mediator. This is why I should never get married. This lady was having an airway operation, and she was lit on fire in the course of the operation. She was awarded $30 million. $30 million. Now, all that being said, how do we prevent these fires from happening to you during your bedside procedures? Well, it's very simple. It boils down to this one concept. You need to have 3 things in close proximity to develop a fire. And if you remember nothing else from what I say, remember this one slide. 3 things that come together to create a fire. You need an oxidizer, you need some kind of a flammable fuel, and you need an ignition source. And when the 3 of those things come together at one time, you're at risk for fire. Oxidizers, fuels, ignition sources. Now, in surgery, we tend to break them down by responsibility. We say, well, the surgeons, they're responsible for the electrocautery and the lasers. Those are the ignition sources. Whoever's giving the anesthesia, they're responsible for the oxygen. And the nurses are responsible for the fuel. Let me suggest to you that that's a bad idea, okay? Because you don't want to pin the responsibility for individual things on individual people. This is a team effort. Medicine is a team sport, and any procedure that we perform, we're all equally responsible for knowing what's going on. And in fact, in all the operating room fire cases that I have attempted to litigate or mediate, it inevitably came down to the fact that somebody didn't talk to somebody else about what was going on in the operating room. So the surgeon didn't bother to ask what the oxygen level was. The anesthetist or the anesthesiologist or what have you didn't bother to ask the surgeon if they were going to be using a potentially flammable cautery source. Nobody stopped to check that there was an alcohol-based prep on the patient's skin. That kind of communication is so critical to preventing these fires. Now, everybody assumes, well, okay, if you're not using supplemental oxygen, you're probably fine. Well, here's the thing about that. It doesn't just have to be supplemental oxygen. When you use oxygen, it's dense. So if you're giving oxygen, the patient is supine like this, if you can see me on the webcam, and they've got oxygen on. All that oxygen is flowing around their nose and mouth, and it's pooling down by their neck. So even if you take the oxygen off here, you have two big reservoirs of oxygen just sitting here between the neck and shoulders in the supine patient. Oxygen is going to collect in those low-lying areas, and it gets absorbed in the fabrics. So you haven't washed that out, so you're still at risk for developing fires. Similarly, what happens when nitrous oxide gets heated? For example, during the process of inhalation, it gets warmed up. What does it do? It releases nitrogen and oxygen. That's what nitrous oxide is. So nitrous oxide can be flammable as well. So what do we do about oxidizers? Well, first of all, we should always minimize our use of open oxygen. And this is one of the things I want to suggest to you. If you have a patient who requires 30% oxygen or more, you need to have a closed oxygen system. Closed oxygen systems are things like LMAs and endotracheal tubes. The patients who are going to be at highest risk are the patients who are getting nasal cannula or face mask oxygen in the upper neck chest region for procedures, but they're getting free leak of oxygen around a face mask or around nasal prongs. Those are the patients you have to be careful about. So if they require more than 30% oxygen, you need to do a couple things. First, you need to close the system. So you need to get rid of the nasal cannula or the face mask and secure a system like an LMA or an endotracheal tube. And secondly, avoid any of those ignition sources, because again, with that fire triangle, all you have to do is remove one arm of the triangle and you'll prevent the fire from occurring. So if somebody requires an oxidizer, take away the ignition source. If you have to use an ignition source, you got to turn down the oxygen. Take away one element of the fire triangle, and you're going to prevent a fire and keep yourself out of trouble. So again, talking about delivery systems, the ones on the left on your screen are where we get into trouble. Those are patients who are getting nasal cannula and face masks because oxygen is just blowing around and it's collecting down here in the shoulders in the pool down by the neck. If you need more than 30% oxygen, the current guidelines, recommended guidelines, are you need to close the oxygen delivery system. So you need to either use an LMA, as seen in the top, or an endotracheal intubation with a cuffed system. Now, it's not foolproof. It's not completely fire safe, but it will reduce your risk because you've reduced your free leak of oxygen and reduced some of your oxidizer. Similarly, if you're using anesthesia machines, you can use an oxygen blender or a fresh gas outlet, which helps you titrate the amount of oxygen that's coming out. And helps you prevent any of that oxidizer from getting loose. Similarly, ignition sources. So there are a lot of different ignition sources. Electrocautery is probably the number one that we think of. When you're doing bedside procedures, people have that little portable electrocautery device, or they bring a Bovie electrocautery to you. That's a risk. That's a major risk. Similarly, a bipolar. But I'll tell you that lasers, skin laser procedures, huge risk. The dermatologists are always at risk when they do these skin laser procedures. Similarly, light cables. So somebody's coming to do a bedside endoscopy, an airway endoscopy, an abdominal laparoscopy. Those light cables pose a risk for fire and burn formation. But in reality, anything that plugs in can create a spark. So we had a case a few years ago where the anesthesia machine sparked and started a fire. Now, you need to be aware that anything that plugs in potentially creates a spark, and that is where your ignition source comes from. And we have all kinds of ignition sources in the operating room. There have been cases around the country of people being lit on fire during the process of defibrillation. Usually if you're being defibrillated, you've got other problems to think about, but imagine if you're successfully defibrillated, but then get lit on fire, because this is an ignition source. All of these monopolar and bipolar electrocauteries. Notice these catheterization wires that provide electrical stimulus. There are numerous reports of fires during cardiac catheterization. Again, those are all ignition sources that can start fires. Similarly, light cables. If you're using high-intensity light cables, by the way, those things get obscenely hot at the end of them. So make sure you turn them off and disconnect them near the ends of your procedures, and don't leave them lying around where they can burn somebody. And finally, here's the big one, the Electra surgery unit, what we traditionally call the Bovie. You have to be really careful with this. Some people have this misconception that you can take a red rubber catheter and guard the sleeve. This is a terrible idea, and it's actually been advised by the FDA not to do this, because you can get a short right in here that causes the potential for fire, and you can get burn going all the way up the device. So you should never use that kind of rubber sleeve. If you need to guard the tip so you don't have this long, unguarded tip, then get a guarded tip Bovie, okay? Rather than trying to sort of makeshift a rubber sleeve for yourself. But again, if you're going to use it, the key is to communicate to your team, hey, I've got to use a Bovie. What's our oxygen level? What are our fuels? What's our fire risk here? Similarly, laser surgery. Any lasers used around the face or the airway can ignite fires in an oxygen-enriched environment. So a dermatology consult comes to your ICU and says, yeah, he's got all these weird skin lesions. We're going to laser them to try to help them. And you've got a patient who's got a face mask, and they're getting 50% oxygen. 50% oxygen, they're going to use a skin prep, and then they're going to fire a laser around the face. So your fire triangle is incredibly close proximity, and that's where fires come from, because those lasers are highly flammable. And then you say, well, what are the fuels? Well, gosh, there are all kinds of fuels in the operating room or in the bedside procedures. You have extrinsic fuels, so things like endotracheal tubes, because endotracheal tubes have highly flammable materials in them. Same thing with nasal oxygen tubing. That plastic is flammable. Drapes and towels are flammable. But you also have intrinsic fuels. Patient's fat. Fat is highly flammable. For those of you who don't have fat patients, come to Texas. We've got plenty of them. That fat is highly flammable. Muscle is flammable, but the big one here, skin and prep solutions. Those skin and prep solutions are big, big, big risks, especially because they're alcohol-based, and that alcohol is flammable. So always be aware of that. You've got a whole laundry list of fuel sources that can ignite in your procedures listed right here, and there are lots and lots of them. So just be aware that you have fuels everywhere. So just one tip on that note about the fuels, alcohol-based prep solutions, they have to be dry. Now, at my institution, we have a 3-minute wait time. I would encourage you to turn that to a 5-minute wait time if you're using an alcohol-based prep solution. Why? Look at this picture on your right. So this is the umbilicus, and we use this with our FDA working subgroup on prevention of surgical fires for a good reason, because you can see there's a huge pool of this alcohol-based prep solution right in the umbilicus, but you'll notice we have a knife, not an electric cautery here, because we have this pool of alcohol-based prep solution. The other thing I want to warn you about alcohol-based prep solution is, what does it do? It goes downhill. It always follows gravity. So if you're doing alcohol-based prep in the neck and the patient's supine, guess what? You're going to have a big lake of prep solution just sitting around the neck and sitting around the shoulders, and you've got oxygen blowing from the face around the neck and the shoulders. So now you've got two elements of the fire triangle right here, and all it takes is that ignition source, and the whole thing goes up in flames. So alcohol-based prep solutions, be careful, because it pools around you in addition to pooling in places on the skin, and when it does light on fire, it creates a blue flame that's very, very hard to see. So just some pictures from Dr. Constantine's operating room of some of the many fuel sources that are available to you in the operating room. So you've got drapes, you've got towels, you've got plastic tubing. All these things can be burned. So why does this matter to you? Real quickly, just a quick polling question. During the bedside timeout, okay, in your ICU, do they do a fire risk assessment? I'm curious. Okay, so there we go. Most of you don't do a bedside fire timeout, okay? I want to suggest to you that you should be doing a bedside fire timeout as a part of your procedures. And it's very simple and very straightforward to do. You need to be aware that anybody doing procedures in head, neck, face, or upper chest are in your high-risk procedures because, again, that fire triad is in very close proximity. That's where your oxygen, your fuel sources, and your ignition sources are all close by. So those are things like bedside tracheostomies, any cutaneous procedures with open oxygen, things like ECMO delivery, pacemakers, skin biopsies, bronchoscopies. Many, many ICU bedside procedures are at significant risk for developing these fires. So a few years ago, one of my co-collaborators and I actually did a survey of the American Academy of Otolaryngology and asked how many fires they had. And it was interesting. We had 350 responses, and a full quarter of them had had at least one operating room fire in their career. And 10 surgeons had had 2 fires apiece. 2 surgeons had reported 5 fires apiece. If you can see me on the webcam, look at the incredulity on my face. 5 fires apiece. If you're getting 5 fires, you needed to figure something out after the first one to prevent it from ever happening again. But let's just quickly look at the details. You can see there's a pretty even breakdown, a pretty even distribution here between endoscopic airway surgery, oropharyngeal surgery, transcutaneous surgery, and tracheostomy. These are kind of our 4 big risk factors. These are our 4 big risky operations. So trachs, cutaneous surgery of the head and neck, anything in the oropharynx, and anything in the airway, again, because of the proximity of those elements of the fire triangle. So let's talk about our essential tips and tricks. Now, I already asked you about how many of you do a fire timeout, and the vast majority of you said no. That's a terrible idea because it's very easy to do a fire timeout. It's very quick. I'm going to show it to you real quickly. Before you begin any bedside procedure, just discuss the elements of the fire. Say, what's our oxygen level? Ask if you have an open or closed delivery system of oxygen. Are we using any ignition sources? Are we going to use a cautery device? Are we going to use a laser? What are our flammable materials, including PrEP solutions? So let's communicate those before we start those procedures, and that'll keep us out of trouble. And so the Anesthesia Patient Safety Foundation actually developed this fire prevention algorithm, and this is readily available for everybody for free, which is to just say, is a patient at risk for surgical fire? So those are patients who are going to have head, neck, and upper chest procedures. Do they require supplemental oxygen? More than 30%. And if that's the case, you need to secure your airway because that's going to decrease your risk of fires. And so these new ECRI Institute and Anesthesia Patient Safety Foundation say that during head, face, neck, and upper chest surgery, you should use open air if the patient can maintain a safe oxygen saturation. If they cannot, then you need to secure the airway with either an LMA or an endotracheal tube. And I always tell this story. If I have time, I'll very quickly tell you this anecdote. I had sinus surgery about 1.5 years ago. One of my partners did it. I had allergic fungal sinusitis. And when they brought me into the operating room, the first thing they did was put 100% oxygen on me. And I remember looking at my anesthesiologist, who's a dear friend of mine, and I asked her, I said, why do I need 100% oxygen? I'm a completely healthy, mid-40s guy. And she said, we just do it routinely to pre-oxygenate people. Well, that's the kind of theory that will get you into trouble. If patients can do well on room air, keep them on room air. Only use the oxygen if they absolutely need it, and then you've got to secure the airway. And this is the fire risk assessment. There are a couple different ways. There are posters available, and we're happy to give those to you. Here's the scoring system. If your surgical site is above the xiphoid, you're using open oxygen delivery sources, and you've got an ignition source in use, that's 3 different points. If you're 0 to 2 of those things, you've taken away one arm of the fire triad, go ahead and use your normal precautions. But if you've got a score of 3, then you've got to go with a high-risk protocol for fires. And a big part of that high-risk protocol is just having an assignment for everybody to do. So if you get a high-risk score of 3, you need to have a continuous conversation during the procedure, including, hey, let's not use an open oxygen source. Let's keep our oxygen to a minimum. And let's have everything ready for what to do in case a fire occurs. So if a fire happens, what's everybody's role? Anesthesia, you're going to yank the tube. You're going to turn off the oxygen. Surgeons, you're going to grab a pitcher of water and pour it on the fire. Nurses, you're going to pull off all the drapes. And accessory person standing there, you're going to go get the fire extinguisher. You need to make sure that you have a plan available for these high-risk fire procedures when somebody gets the 3 out of 3 score in that bedside timeout. So quickly, let's just look at a couple of these procedures. Cutaneous surgery, well, again, the Fire Triad is right there. You're using the Bovie or a laser, anything that sparks. You've got patient hair, skin, alcohol-based PrEP solutions, and you've got an oxidizer. So those are the cases where you have to be really careful about O2 being given by nasal prong or face mask because you get oxygen trapping around these flammable fuels with an ignition source. So these are high-risk procedures. And in fact, in 1998, the Arizona Medical Center ran a beautiful simulation of what happens, and I'm going to show you this in real time. So they've got a dummy here that's prepped in an alcohol-based PrEP solution, and it's completely wrapped up the way you would for a sterile procedure. And you can see the Electra surgical device there being used to cauterize the skin. Within 5 seconds, they saw smoke and heard a pop, and you can see the smoke starting to billow up here. So you say, okay, we have a problem, right? So what happens at 13 seconds? 8 seconds later, boom, this whole thing has ignited into a gigantic fire. Okay, even after you recognize that there was a problem. And by 24 seconds, look at your model. It's completely up in flames. And then you pull off the drapes, but what's happening is underneath the drapes, everything's burning because, again, you've got alcohol-based PrEP solution and oxygen stuck down in those reservoirs, and the fire comes up there. And then you pull off the drapes, and you can see the extent of the damage done, which is really impressive. So that's always a scary thing. Now, this is a video. This actually goes way back to the 1950s. The Royal Air Force looked at oxygen-enriched environments and how easy it is to actually ignite things on fire, including clothing. So you'll see a spark, and then you'll see how quickly the flames spread. And I apologize, the webcast is giving you a little bit of a jerky motion on the video. But that quickly, in oxygen-enriched environments, these elements of clothing, like drapes, can go up in flames very, very quickly. And here's another example. So they're going to give a little spark to an oxygen-enriched environment, and watch how quickly the clothing goes up. So there's the spark being delivered, and then there's the clothing catching on fire. So again, ignition source, oxidizer, flammable fuel, and that's how quickly those things happen. So just be aware of that with the cutaneous procedure. So how do we prevent this? First, communicate. Don't give oxygen if it's not absolutely necessary. Communicate with your teammates and say, hey, do you have to use supplemental oxygen? If you do, can we secure the airway? If we can't secure the airway and we have to use cutaneous oxygen, let's take away another arm of the fire triangle. Let me not use an ignition source. Let me not use the Bovie. Let me not use the laser. Take away some other element. Hey, how about we don't use alcohol-based prep solutions? And don't even get me started, guys, on the whole ChloraPrep issue, okay? I have a lot of issues with the way ChloraPrep is being utilized. I actually stopped using ChloraPrep for head and neck procedures for this very reason, and I use betadine. Endoscopic airway surgery, I won't dwell on this because this is far more relevant to ENTs than most of you in the critical care setting, except to say all three of those elements are in about a 3-centimeter radius. So we put ignition sources, fuels, and oxygen in a 3-centimeter radius. And so when we're going to do that, we have to be very careful about taking away one arm. Either take out the endotracheal tube, stop the oxygen, or don't use an ignition source like a laser. But I do want to show you just some of our experiments because this is kind of the fun stuff. So we decided we were going to test the laser tubes, and so we tested laser-safe tubes and non-laser-safe tubes. So here's a non-laser-safe tube, and it turns out that we could get ignition with a sustained flame around 45% oxygen. Underneath 30%, we got ignition without a sustained flame, but I'll just show you one example of what that looks like. So this is a non-laser-safe tube, and I'm going to fire a CO2 laser at 5 watts, and this is in about 45% oxygen, and watch how quickly that thing ignites. It just gives you a flash fire, just like that. We turn off the oxygen, and everything's fine. But this is how quickly that damage spreads. That's the fire going up that endotracheal tube in very, very short order. So it happens really quickly. And here's just a view of an endoscopic surgery. Now, you're not going to see much because I'm doing endoscopic laser airway surgery. But what you're going to see is in a few moments here, you're going to see flames start to come out. And then what I want you to really pay attention to is look at the smoke coming out down here by the lung fields. You're going to see the smoke start to come out. So there's the fire. You're going to see me turn off the oxygen here because I'm yelling, fire, 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 turn off the oxygen. And you see, okay, the oxygen's off, but there's still smoke coming out. You can see the smoke coming down the lung fields. But watch this from the endoscopic view. This is that same procedure from the endoscopic view. And I'm going to do a little laser supraglottoplasty here. So CO2 laser, unreinforced endotracheal tube, misfire the endotracheal tube, fire, fire, fire. You can see the flash. I'm going to pull out the tube, pull everything out. So here's what the damage looks like that quickly. This is me with one foot on the forehead trying to pull the tube out because it's fused to the mannequin. You can see the damage to that model of the larynx incredibly quickly. So that propagates very, very quickly. Those fires are incredibly fast. They spread quickly. And again, oxygen-enriched environments, flammable fuels, and laser sources, and you can see the damage that occurs in very short order. So, of course, that's going to happen because I wasn't using a laser-safe tube, right? What idiot fires a laser at a non-laser-safe tube? Well, so what happens if you use a laser-safe tube? If you look at this data, it turns out you get no ignition with a laser-safe tube because the laser-safe tube is laser-safe, right? Well, it's kind of laser-safe. You can actually crank that laser up to 60 watts, and it doesn't start a fire, okay? But it takes the tape off of the laser. You can actually see here's a laser-safe tube. I fired a laser at it, and we can take the tape off of it, but we didn't start anything on fire, except for one caveat. The laser-safe tube isn't 100% laser-safe because the distal end of it, past this metal mark right here, the distal end of it is not laser-safe. And if you hit the distal end of it, you can get a fire there, and you can see the flame and how quickly that part of it burned out. And that flame spreads on the inside of the tube. You can see the flame still coming out here. So the laser-safe tube is laser-safe on the reinforced part, but not on the unreinforced distal tip of the tube. So just be aware of that. And then finally, for those of you who are incredibly bored, I published an article in the Journal of Otolaryngology and Head and Neck Surgery last January, and they actually did a podcast on it. And if you have time to listen to that, I really worry about your well-being mentally. You need to find a better hobby. But if you're bored, scan that QR scanner, and you can see the podcast. So this was just a simulation of an experiment that we did. You can see we're using an airway mannequin here, and we're setting it up just like we would laser airway surgery. And I've tied two plastic baggies down to the end to simulate lung fields, and we're going to pipe oxygen into them and fill it up here. I've got the CO2 laser, and I'm going to fire the laser like I'm doing laser laryngeal surgery. So here I am. I've got a reinforced endotracheal tube. I've got methylene blue in the cuff. I've got wet pledgets to protect it. So I'm doing everything right by the book. Okay, and what happens? Well, it turns out that 40% ignition, 40% oxygen, I could still get ignition in a sustained flame. Even at 29%, just under that 30% cutoff, I did get a small sustained flame. And I got a really wicked fire at 100%, and I'll show you those results in a little bit here. So here's just one video from that simulation. So if your ENT ever comes in and says, hey, I need to do a little laser procedure around the endotracheal tube, just be aware, I'm going to fire the laser, and I'm going to see flames because I accidentally hit the distal tip of the tube, which is not reinforced. Now, I'm going to do everything the right way. I'm going to pour saline down to extinguish the fire. I'm going to pull out all the burning materials. And so I've treated the fire, right? Keep this in mind as we go through the rest of this talk. Just keep that video in mind. Because from that video, here's the endoscopic view of the damage that was done from that same video. You can see there's a horrific burn mark. You can actually see the methylene blue down here where it escaped from the balloon when the balloon melted. The methylene blue just fused down into the airway. And you can actually see where the methylene blue melted down into the mannequin model there. So even with a small flame like that, you can get incredible damage propagating down the airway from these types of laser airway fires. So just be aware of those possibilities. And this is even at a low concentration of oxygen. You can see melting of the mannequin. But even at a low concentration of oxygen, I think this is 30%, you can see how much damage gets created in short order. So, oropharyngeal surgery, you won't be doing as much of this in your bedside ICUs, but be wary when an ENT like me comes in and says, hey, I found something in the throat that I want to biopsy real quick. Ask them a question. Are you using an ignition source to do it? You're going to use a bovie. You're going to use a laser. You're going to use a suction bovie. If so, do we have an endotracheal tube that can light fire? Tonsil sponges. People say, well, put a tonsil sponge down. That seals the leak. Yeah, those tonsil sponges are flammable. And what's our level of oxygen? Do we have a secured oxygen source? So turn down the oxygen, think about your air leak, and try not to use ignition sources when you have to do something in the oropharynx. And this was our model of oropharyngeal surgery. By the way, for those of you who don't know, my most famous move in my career was, you can see me putting my hand to my face here, was developing this mechanical model of a tonsillectomy using a whole chicken. If you ever told me that the chicken was going to be the model that I was going to get famous for, I would have laughed at you, but hey, it's working for me. So there's a model of a tonsillectomy just using a whole chicken, and you can see a fire creates very quickly in oxygen-enriched environments. So be aware of that. Now, there are other devices that we've tested that are actually fire safe. So there are devices like a radiofrequency ablation wand that don't spark. They don't create that ignition. So by using a device like this, instead of an electrocautery device, you're able to avoid that ignition arm of the Fire Triad. But then even after you use it, if you go back to using an ignition source like a bovie, you can get a fire in that same model. So while it is protective against a fire, it's not preventative against a fire. So there are certain devices that are much safer for fire formation than other devices, just to be aware of that. And finally, tracheostomy. There have been numerous case reports of fires during bedside tracheostomies. And again, why is this? Because you're blowing oxygen down into the airway, okay, and somebody's going to use an ignition source right here on the neck. And there are a couple different things that can happen. One, if you have iodine or flammable alcohol-based prep solutions, alcohol-based prep solutions can ignite on the skin. So that's one thing to be aware of. The bigger thing to be aware of in the tracheostomy itself is if you inadvertently puncture the trachea using an electrocautery device. Now you've got an endotracheal tube coming in from above, blowing oxygen down into the trachea, and you're going to enter the trachea here with an electrocautery. So oxygen, plastic tubing, cautery in that close of a proximity. That's a fire waiting to happen. And there are numerous reports and lawsuits over patients who were ignited on fire during the course of tracheostomy. So be aware of that during your bedside procedures. If somebody's doing a bedside trach, ask them, are you using a cautery device? If so, what can we turn our oxygen down to? If we can't turn the oxygen down, you got to turn it off when they enter the trachea, and you got to tell your surgeons, hey, don't enter the trachea with an electrocautery. Enter the trachea with something that won't ignite on fire. and don't use the electric cautery at that point, because that's where you're going to create problems. The other situation we run into is the awake tracheostomy under local anesthesia. Somebody who's getting nasal cavity or face mask oxygen. Again, be aware of using electric cautery because that oxygen is blowing all around. And there's been a case recently here in Texas of a lady who was burned terribly during a fire because she had a face mask on with 100% oxygen that was blowing around, and the oxygen ignited during the course of the operation from the ignition source. And then finally, just a little word about drapes and light cables. We know that light cables and drapes, they don't actually cause fires. But the modern sort of cellulose-based ones, it's harder to ignite the new drapes than the old ones, but they will melt and they will burn. And this takes us back kind of full circle to where I started, where you can get these things very early on. So they're really not a high risk for ignition, but it is a potential for patient burns. So be aware that those light cables get very, very hot. They're about 190 degrees Celsius, and don't let those light cables sit on patient skin. Okay, so we've talked about fire prevention, why these fires occur. So what do you do if a fire occurs? Well, again, the ASA algorithm says this. There's a difference between fires on the patient and fires in the patient. Fires in the patient from the airway, pull the tube, stop all the gases, remove all the flammable material, pour the saline in. In the non-airway fires, then you need to stop all the gases, pull off all the burning materials, and then put the burning materials out with saline. Then, after that, that's when you start paying attention to your patient. Reestablishing ventilation, checking the trachea for any sort of residual pieces, maintaining ventilation, and then devising a management strategy. So again, on the patient, stop the gases, take out the burning materials, care for the patient, okay? Fires in the patient, a little bit different. If the fire is small on a patient, you can pat it out. Now, we use this picture in our FDA slide set. I don't know anybody who's ever actually done that. Grab a wet towel and smother it. I think if you put your gloves on there, you're going to regret it. Grab a wet towel and smother that flame if it's a small fire. But usually it's going to propagate very quickly, as I showed you from those Arizona Medical Center trials. This is going to propagate very quickly, so you've got to just rip off all the burning material to get it off that patient's skin and then put out any fires that they have. If they're still burning, use a CO2 extinguisher, and all of you should know where your CO2 extinguishers are in your ICU settings. You need to know where the CO2 extinguishers are. They should be installed readily available in your ICUs. We are not recommending dry chemical water or water mist or fire blankets. Just the CO2 extinguisher is the most effective thing. So, next question. Does your facility provide a simulation program to reinforce the roles of the team member at these bedside procedures? I'm curious to know. Do you guys do fire simulations? We do. And the answer is about half and half. So about half and half, 50 and 50, are doing these fire timeout or these fire drills essentially. Now, airway fire is a little bit different. Pull the tube out, stop all the gas, pour saline down the airway, and then care for the patient. So just a different algorithm depending on where the location of the fire actually is. Now, you remember that video I showed you endoscopically using my Airway Larry mannequin? So I saw fire, I saw flames, I pulled out the tube, I poured saline down the airway, just like you're supposed to do. Great, everything's fine. This is the same experiment that we did, but this is the external view. And so I just want you to watch this for a second. So remember the internal view that I showed you, where the fire was out and everything was good. This is the external view of that same fire. So there's the flame. I say, fire, 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 fire. We're going to pull the tube out. I'm going to pour saline down the airway because my ever-ready nurse has everything we need for that circumstance. And I'm, from my end of things, thinking, okay, problem solved. Fire's out. I see some smoke because I put the fire out, right? Something didn't seem right. She kept handing me buckets of water. Watch what's happening down in the lung fields. And then watch her reaction. So those fires continue to propagate because that oxygen is residually trapped down in the airway. So be aware that you may need to have a fire extinguisher, you may need to have saline, a lot of different things you may need during the course of that process. So let me start to wrap up here. Surgical fires are 100% preventable. How do we prevent them? Teamwork, communication, education. Okay, we've got to start communicating during these procedures. I'm appalled sometimes when I do bedside procedures that ICU staff isn't there with me at the bedside. I would think they want to be there. I certainly want them there because I'm not a smart enough guy to know what to do if things start to go haywire. So the more smart heads you have in the game at all times, can keep you out of trouble. We've got to communicate better during these procedures about preventing these fires from happening. Educating your entire staff. Preoperative risk assessment. So again, I encourage all of you to add that fire assessment score into your timeouts before procedures, and doing fire drills so people know what to do, what happens if something happens during a fire drill. Okay? So to summarize, since the dawn of man, we've tried to create fire. Fire has been good. It's led to modern civilization. Fire in your ICU setting, however, is terrible. Okay? Remember the fire triad. Ignition source, any sort of oxidizer, and any sort of flammable fuel. Anything in the upper chest, neck, face, and head region is at highest risk for that fire triad being in close proximity. And again, communication is the key to prevention. So please, eliminate one arm of the fire triangle, and you've saved yourself a tremendous amount of grief. So on behalf of my team, I want to just take 1 second to thank Roy Constantine. I want to thank Samantha and Lori from the Society of Critical Care Medicine. You guys don't know this, those of you who are listening. I am a tremendous pain in the butt to get organized to these kinds of things because I'm always on the go. I'm traveling a lot. I've got a million things on my plate, so I tend to get these things done at the last minute. I think I gave them about 9 simultaneous heart attacks. So I want to thank you guys for your patience in getting me to do this webcast. I'm really incredibly honored that you would ask me to do it, and I'm flattered that you would think of me. And I really want to thank you for your diligence in getting it done for me. For those of you who are ever in Houston, I do play in an 80s hair metal cover band. That is me on the weekends. If you want to come find me, I will pretend that I do not know you. So you can come spend some time there, and I'll end with this. Sometimes a flamethrower is a better motivator than Hawaiian Shirt Friday. And finally, try not to need me, okay? If you learned anything from me today, hopefully you won't need me. But if you do need me, here's my contact information. And I'll leave this up for just a minute. Now, it's about 1:45, 1:47. We have about 10 minutes for questions, so I will stop here. As questions come in, I am going to roll out a couple more slides for you. If I can do that, which includes some of our resources. Some of you have asked for some information about where we can get this. This is an old slide. I will get you some better updated information, but I want to just tell you that the Preventing Surgical Fires Initiative is a collaborative of a number of partner groups that are involved in surgical fire prevention, and in particular, the Council on Surgical and Perioperative Safety, which is part of the American College of Surgeons, has been working with the Joint Commission. I've been working directly with the Joint Commission on this Preventing Surgical Fires initiative. Many of the slides that I have shown you today are available to you that you can get from our Preventing Surgical Fires initiative. Not my original video slides or things like that, but a number of the kind of basic information slides about fires, about fire timeout, about scoring systems, all that kind of stuff we have available for download for you that you can take to your home institutions there. So a lot of these resources are available to you, and we will provide them to you if you should ask. So on that note, I will stop, and I will take any questions that anybody has. And again, I appreciate you paying such close attention to me and my rantings for the last 45 minutes.
Okay, can you hear me?
I can hear you beautifully, Roy.
Okay, very good. Okay, so Soham, ICU nurses are not OR nurses.
Correct.
And many times, there may be a bedside procedure that's done in the ICU, as you had said. But, what type of policies or what have you seen, created where checklists may be used, or that ICU nurse becomes empowered and is able to stop the line,
That's a great question, Roy, and to whoever asked that, I commend you for thinking along these lines, because I think you brought up a really important point. When we look at sort of where we're going in healthcare, many of us are looking towards more lean systems, and we use Toyota Production Systems methodology to try to improve our efficiency and try to improve our outcomes. I think the way you phrased it is critical. At what point are the ICU nurses empowered? And to me, the answer to that is that the ICU nurses are always empowered, right? If you're doing a bedside procedure, we're all empowered. Every single person doing that procedure. The hierarchical days long before I went into training, hundreds of years ago, where the surgeon was the commander of the ship and made all the decisions and did all this kind of stuff. Those days are long gone. Okay, we're a team, and every member of the team plays a vital role. And one of the things that we talk about at my institution is the surgeons will typically say to the nursing staff, to the residents, say, look, you're all extremely smart people, and you're here for a reason. So if you see something that looks off, speak up and say something. So those ICU nurses should be empowered in the culture of your institution to be able to stop the line at any point and be like, you know what, I heard this big brown guy rambling on the webcast about something about ignition sources in the presence of open oxygen being a terrible idea. Let's stop this for a second. Let's give the big time out here. Put a stop to this and say, let's look at this a little bit more carefully because I think this poses a risk for a serious safety event. So all of your ICU nurses should be empowered in that process, in the checklist process, at any point to say stop the line. Maybe it's an antibiotic issue. Maybe the antibiotics weren't given on time. Maybe the prophylaxis, PE prophylaxis wasn't given, DVT prophylaxis wasn't given. Whatever it is, the ICU nurses, just like every member of that bedside procedural team, needs to be empowered to say, let's put a stop to this until we sort this out before we run into trouble.
Well, thank you. There's two more questions. The other question reflects on teamwork and reflects on escalation. So if the nurse is looking at the surgeon and the surgeon's not doing the timeout and there's no mention of a fire risk score, and there may be an anesthesiologist or an assistant there or other nurses, I mean, who has the role? Who should be introducing the score? Or is it good enough, and I know I heard your slide presentation, just to be aware that this is a high-risk score and not necessarily run the risk score itself? So who has the role?
Well, now that's going to be partially institutionally dependent. So let me talk about a different couple facets of this. So first of all, you said, who's going to be empowered, who should really have the right to do that? Is it something that's okay to just not talk about? Well, the problem is, those of you who are watching this webcast now will be hopefully attuned to these issues, right? You're going to say, look, I get that there's a risk here, but the surgeons might not be, right? The surgeons may be completely oblivious to the fact that this is a high-risk procedure. Or the dermatologist who's coming by to do the skin biopsy probably has not realized, like, oh, wait, there's free-flowing oxygen around the nasal cannula. So just because you didn't talk about it doesn't mean that everybody's paying attention to it. And that's why I think it is critical to have that as a spoken part of your procedure. Now, the first part of your question about what about if you're not doing a timeout or whatever, I would ask all of you who are in that situation to think very carefully about the modern age of medicine that we live in. At my institution, we can't sneeze without doing a timeout first, okay? If I need to go eat lunch, I got to do a timeout to make sure I'm eating lunch safely. We do everything by checklists and timeouts because it's been shown time and time again to decrease the incidence of adverse events. So especially for surgical procedures and for bedside procedures, you really need to be doing a timeout. And I, like all other surgeons, are not exactly known for my patience, right? It's not like people are like, oh yeah, he's the most patient guy on the planet. We're known for being notoriously push, push, push. We want to get this done. Let's get going. Let's get going. But that is not an excuse to take shortcuts. So if your institution has a timeout procedure in place, then that timeout needs to be done. And that ICU nurse needs to be empowered to say, hey, guy, guess what? Or hey, gal, guess what? This is our ICU, and you are here doing a procedure on our shared patient. You must follow the appropriate protocols. The protocol says we are going to do a timeout. As a part of that timeout, we are going to assess the fire risk, and we are going to say that, hey, this is a high-risk fire procedure. Have we taken the appropriate steps? Do we have the appropriate precautions in place? Have we addressed those issues? So I think that a lot of this has to be culturally dependent on your institution. Your institution has to have empowered the ICU nursing staff, the anesthesia staff, to say, hey, surgeons aren't going to bully you and run you through all this. We're a team. We're going to pay careful attention to serious safety events, and a big part of that is we're going to adhere to the checklist that we know are best practices at our institution.
Soham, thank you. The last question, and there's a lot of this in the literature, is on the use of cognitive aids. In my facility, we started using little tags and placing them with the fire triangle on flow meters. And then in other facilities, you may see signage near the oxidizers. I mean, what is the role of cognitive aids in the operating room, and how does that help?
So that's a really, really great question, and I want to commend whoever asked that because I think that's a really important question to ask. Those sorts of cognitive aids, what do they do? I'm not a psychologist, and I'm probably the last person on earth who can qualify to comment on this, but what they do is they immediately trigger a recognition, right? So all they're trying to do is to stimulate a sense in you of, hey, wait a minute, I remember thinking at some point that this could be a high-risk procedure for fires. So those cognitive aids are a great idea. Just have a little fire triangle right next to your oxygen blender, right? Your little oxygen blending device that tells you what percentage of oxygen is going. Have a little fire triangle picture with maybe like 30% or higher with a slash through it so that you know that if you're above 30%, you better pay attention. Those kind of cognitive aids are a great idea. Now, that said, in the interest of full disclosure, we don't do those at my institution, and that's something that I think we need to start doing. We have the big fire checklist protocol, that 3-point Christiana checklist we have up on our wall next to our big timeout checklist. but we don't have the specific ones on the oxygen gas blender, on the oxygen delivery source. But that's a really great idea. We could probably put one on the electrosurgical unit, since that's the most commonly used device anyway, is to just put a big, red flag on the bogey saying fire risk. Those kinds of cognitive aids, they trigger things in people's minds. And again, I think for all of you who are listening, I know that a lot of what I've talked about today is probably coming out of the clear blue. This is stuff you've never thought about before. I'm hopeful that now that you are thinking about it or have thought about it, that you will take it back to your respective institutions and say, hey, listen, I heard this talk. This guy was completely insane, but he did make a good point about running the risk of lighting things on fire. So let's put in these practices in place. Let's put red flag warnings on oxygen delivery units. Let's put a red flag warning on an electrosurgical device so that people are aware of those risks.
Well, I'd like to mention that we're now out of time for questions. And again, I'd like to thank everybody. This concludes today's Project Dispatch webinar. Thank you to Dr. Roy for your efforts preparing for and delivering this informative webcast. And thank you to our audience for your participation. Society of Critical Care Medicine offers many webcasts throughout the year, announced by email and in our e-communications newsletter. We look forward to welcoming you the next time.